Today we're going to be talking about pulse oximetry. We're going to answer a couple questions, including how the pulse oximeter actually works and how it gives us these two numbers and this graph. We're going to be talking about what these numbers actually mean and how oxygen travels from the air into something that's detectable by this pulse oximeter. We're going to be talking about what to look for when using pulse oximetry, what this tells us about the patient, and finally we're going to talk about how we can apply this knowledge to our practice. So question number one, how does the pulse oximeter work? It's a small plastic device. Typically this is the most basic kind that you can find, and it's typically clipped on a finger, but there's a couple sites it can work. It'll work on an earlobe or a toe, for example. And the way this actually works is it shines an infrared light through one side to the other where there's a sensor, and it detects the amount of light that's absorbed. So a hemoglobin that's saturated will absorb this light, and then the sensor picks that up, and it has a formula to convert the amount of light that passes through into the number of SpO2. So I've got some of the values that it's going to give you on the right hand side here. The main one that we're going to be looking at today is SpO2, which again is that percentage of blood that is saturated, typically with oxygen. This is your normal value, 94 to 100%. You've got your PI, which is perfusion index. This is a number between 0.02 and 20%. We're not going to be going over this too much today, but as this number increases, your confidence in the readings can increase as well. That's the general rule of thumb. This is just saying that the perfusion of the extremity is higher or lower, and in turn, the confidence of the reading is correlated with these numbers. These are the normal values. As you can see on this pulse oximeter, you've got a waveform. This is charted the amount of light that it's detecting over time, and this is how it calculates the beats per minute. And you get this nice little graph here, which we'll be going into later. So here's a case study that we're going to go over, and hopefully by the end of this video you'll have a better understanding of how you could explain what's going on with this patient. So in this situation, we have a 57-year-old male. You're dispatched to a chief complaint of shortness of breath. You arrive on scene, you see this patient. He is not looking too great. Skins are overall a little sweaty, a little clammy, a little pale. He looks extremely short of breath. He tells you he's been feeling short of breath for the past day, extremely weak, and overall just does not feel great. You put him on the pulse oximeter, take his temperature, and take his blood pressure, and these are your vitals you get back. The main things of note that I want to go over are the 99% saturation. And so in this situation, he's feeling extremely short of breath. He looks extremely short of breath. I want you to be able to explain why this might be the case. I want you to explain if you would put this patient on oxygen or not, and how you'd be able to explain it to, say, your EMT partner who's confused about why someone with a 99% sat is short of breath. By the end of this video, we're going to hope to go over some of these concepts. So now we're going to be talking about the Oxyhemoglobin disassociation curve. First, though, we're going to be talking about what a hemoglobin is. So hemoglobin is the part of your blood that actually transports the oxygen. It's got 4 little quadrants, and each of these quadrants has room for one little oxygen, right? The oxygen binds to this quadrant of the hemoglobin in your lungs and then is transported down your body into the tissues where it's supposed to be released, right? And that's how your body works. It's got 4 spots for oxygen, and the cool thing with hemoglobin is as each oxygen binds, it becomes easier and easier for the next oxygen to bind onto the hemoglobin. That's why you get this nice little shape of the curve, which we'll go over later. And vice versa, right, when it's releasing. So back to the curve, right? Disassociation curve. This is telling us at what point this oxygen is going to get released from the hemoglobin, because you don't want the oxygen to just release at any time, because then it's not going to make it all the way to the tissues, right? So your body wants to release it at a certain point to make sure your whole body gets oxygenated. And that's determined by these two things: your hemoglobin saturation and the partial pressure of oxygen. which I think is a really fancy term just to say amount of oxygen. I think that's the easier way to think about it, right? The amount of oxygen in a given volume, right? So this is a high amount of oxygen in a given volume, and this is a low amount of oxygen in a given volume down here, right? So, okay, what is this curve telling us now that you know what these axes mean? This curve is the point in which oxygen releases from hemoglobin, right? Hemoglobin holds on really, really tight until the right conditions are met, in which it then releases down here, right? So on this graph, the main things I want to talk about are up here, right? This is closer to your lungs. So you've got a very high amount of your hemoglobin that's saturated, and you've got a very high amount of oxygen in a given space, right? In your lungs and in the vessels near your lungs. So up here is going to be closer to your lungs, right? And you don't want the hemoglobin to release the oxygen at this point. You want it to bind, but you want it to hold on tightly. And that's what your body does at the top of this curve. But then as you get near the bottom of the curve, right, you have a lower saturation and a lower amount of oxygen in a given space. This is your tissues down here, right? This is the point in which you want that oxygen to release, and because it's less dense, right, the volume is spread out through a larger area, right? Your lungs have a high concentration of oxygen. That pressure or amount of oxygen is lower, right, which causes it to release. And this curve is essentially regulated by your body temperature and your pH. Okay, so what does that mean, and how does that apply to what we're learning? This curve can shift to the left or to the right. So I'm going to draw a little right shift here, and then I'm going to draw a left shift. Okay, what does this mean? Let's talk about the right shift first. So in this right shift, you have a reduced affinity. Okay, this state is going to be caused by a lower body pH and a higher body temperature, right? Which means that you're going to have a higher CO2. And I talk a lot more about CO2 in my CO2 video if you want to go ahead and watch that as well. So what's an example of this state, right? Let's say exercise. What happens when you exercise? Okay, your body needs more oxygen in its tissues, which in turn produces more carbon dioxide, right? And carbon dioxide lowers your pH. You're going to be breathing very fast because you need to take in a lot of oxygen and exhale a lot of that carbon dioxide. Your body temperature is going to rise. Your heart rate's going to rise. And so you're going to see this shift in the curve, right? Reduced affinity. And what's actually going on when the affinity gets reduced is less oxygen in your lungs is going to actually bind to the hemoglobin. It's a smaller amount, but it's going to have a little bit more difficulty binding to the hemoglobin. But the cool part is it's going to release from the hemoglobin way easier. So once you get to this lower part of the curve, right, it hits this lower point where it releases way faster, which means that your tissues are going to be getting way more oxygen, which you need when you're exercising, right? So that's the right shift. And then on the other side, we see the left shift, which is an increased affinity for this oxygen, right? So this is going to be a state where you have a higher body pH and a lower body temperature, which means you have a lower CO2, right? And this is going to be harder for the oxygen to be released from the hemoglobin. That hemoglobin is going to be holding onto that oxygen incredibly tightly, which means you're still going to have a high saturation at most points, especially in the tissues, right? Because this oxygen is going to be, brought in through the lungs, bind to the hemoglobin through gas exchange, and that hemoglobin is going to grab onto it so tightly it's not going to want to let go, which means that you're going to have a high SpO2 because a lot of your hemoglobin is saturated, but your tissues aren't going to be getting that oxygen, which means you can still be hypoxic with a high saturation, right? So this is the more interesting side of the graph to me, and this explains our case study a little bit as well, right? So if you think about it, right, after we know this, we start to think about, okay, well, if we know that this side is caused by a higher pH and this side is caused by a lower pH, then what causes pH to rise and fall, right? And there's a lot of different reasons, and a lot of those are explained in my video about CO2, right? But this tells us what we want to know about the patient and their oxygen saturation. Before we move on to why any of this is actually important, we're going to be talking about Pleth waveforms, right? So this is what you get from your pulse oximeter. Again, it's just what it's actually reading, charted over time, right? You got time down here. So this is your healthy waveform, right? In terms of anatomy of this, you've got your anacrotic limb. That's the part where it shoots straight up, followed by your dicrotic notch, right? This signifies the aortic valve closing, also the start of diastole, right? And then it drops all the way down into this diastolic trough. None of that is important, right? But what is important is that when these features are large and well defined, this is a more accurate reading, right? This is showing that you have a good perfusion state, right? And then on the other hand, this drawing down here is going to be a poor perfusion state, right? You have a situation where either your limb is not perfusing properly or possibly your pulse oximeter was placed incorrectly. I would say after 1 or 2 adjustments, if your reading isn't looking like this, then yeah, you probably have poor perfusion to that limb, and I would try another limb, right? Something that people don't think about with pulse oximeters is you can actually tell if one limb is not getting properly perfused compared to the other by swapping the pulse oximeter from limb to limb, finger to finger, toe to toe, and seeing how the waveform and saturation actually change, which I think is pretty interesting. But what can you learn from this? Basically, you can trust this waveform, right? What this is telling you on your actual saturation is a lot more reliable than this, right? And both of these are acceptable though, but if anything, it's saying that pulse oximeters are a relatively simple and oftentimes inaccurate tool, and it's just another reason to look at your patient in the context of your patient and use your tools as an addition to your assessment. So now that we know the concepts behind SpO2, we're going to talk about some situations over here, right? And my hope is that with these situations, we're going to talk about the relationship between SpO2 in each one of these situations, and that should give you a better understanding of how we can actually apply SpO2, right? So first of all, hyperventilation. So what do we know about hyperventilation? Well, first of all, we're going to have a really basic introduction to end-tidal CO2, right? So one of the basic concepts behind end-tidal CO2 in a healthy adult is this seesaw between respiratory rate and CO2. So say respiratory rate increases in hyperventilation, your CO2 is going to decrease because you're breathing all of that, you're exhaling all of that carbon dioxide, right? It's leaving your body. And what do we know about the relationship between CO2 and pH, right? So when you have a lower CO2, this is going to be like an end-tidal of less than 25, right? You're going to be in a state of alkalosis. And if we know anything about alkalosis from the curve that I was showing you earlier, this is going to cause oxygen to bind very, very tightly to hemoglobin. And it's not going to want to release from the hemoglobin, right? So your lungs are going to take in a large amount of oxygen and store it in your blood. But once it actually gets to your tissue's not going to get that oxygen, right? So your tissues are going to become hypoxic. But your blood is still going to be saturated with oxygen. So you can have a falsely high reading when you're hyperventilating, right? You can have a really high SpO2, but you're actually experiencing tissue hypoxia. And then on the inverse, we have hypoventilation, right? So in hypoventilation, our respiratory rate is going to decrease. And because we're on this seesaw, our CO2 is going to increase, right? So we're looking for an end tidal typically of around greater than 50. And this is going to be an acidotic state, right? So in this acidotic state, going back to the curve, this is going to cause oxygen to do the inverse. It's going to bind very loosely. It's going to reduce the amount that's carried to the cells. It's going to give a low pulse ox reading. And you're going to have a harder time in these patients getting them to respond to direct oxygen, right? Because the hemoglobin doesn't want to bind with the oxygen. So even though you're giving them more oxygen, it's not going to bind, right? So you're not necessarily making a lot of progress. Next up onto bleeding, right? So in a situation where you're bleeding, you can see things like a high SpO2 reading. This might be a little dramatic, but okay, why are we going to get maybe a falsely high reading when in reality it might be a lot lower than that? So when we bleed, we're losing blood, right? Which means we're losing hemoglobin, which means that this 99% is saying, hey, 99% of the blood we have left is saturated. So if we're experiencing severe bleeding in a patient, we're still going to want to give them oxygen, right, in certain situations, although our saturation may be high, right? Because we still need more oxygen, even though our saturation is high. This is just saying that the blood we do have is oxygenated. But in reality, this number is probably going to be a little bit lower. But like say it was 92, we might expect that in our severe bleeding patient that their actual saturation, their actual saturation is this, right? But our number where the saturation becomes concerning should be higher, right? So in a normal patient, we start to get concerned around 94%. Lower than 94%, we start to get a little concerned, right? We're starting to get a little hypoxic, right? But in our bleeding patient, a 94% is going to be a lot more concerning than in a normal patient. Next situation is going to be COPD. So COPD patients actually have kind of the opposite problem, right? So in our COPD patient, they might be on oxygen already, and you might see something like a 92% saturation, and they're not experiencing any shortness of breath, and they say that this is actually normal for them. So why is that? Well, COPD is a condition where your body has excess red blood cells, right? And they have so many red blood cells that there actually isn't enough oxygen to bind onto all of those blood cells, right? So you might actually see some signs of hypoxia, like blue skin. That blue skin, because desaturated hemoglobin appears blue, right? When saturated hemoglobin appears red. So they might look a little blue, but they're not actually experiencing tissue hypoxia because they're still getting adequate oxygen. They just have so much blood that they require a lower percent of saturation to actually properly perfuse all their tissue, right? I thought that one was pretty interesting. Hypothermia. So this is hypothermia, right? Can be an interesting consideration when it comes to accuracy of the pulse oximeter, right? So like in EMT school, they teach you to kind of rub the finger if it's feeling cold before you put the saturation on, because if someone's really hypothermic and you stick the probe right on, it might read something crazy low, like 84%, right? And that's because you have that vasoconstriction, right? Because of the cold, which decreases the blood flow to that particular site. So, and these patients just want to warm up a little bit, and maybe don't take the reading as law. Again, talk to your patient. CO poisoning, right? So in CO poisoning, you might actually see a freakishly high saturation, right? And this is tying into the fact that we're just reading hemoglobin saturation, right? So CO, carbon monoxide, is unique in that it occupies those sites in the hemoglobin where oxygen binds, and it actually binds significantly. It has a higher affinity than oxygen to hemoglobin, right? So it'll take the place of oxygen in this hemoglobin. It's going to take it over, which still means that it's saturated, but your body doesn't run off carbon monoxide, right? So you might have a patient that has a high saturation of hemoglobin because they've been breathing in carbon monoxide, but they're still experiencing that tissue hypoxia because they're not getting oxygen to their tissues. And in a condition like sepsis, well, we talked about sepsis. So, well, sepsis is a state in which your body is acidic, right? So that can be one reason that you're experiencing a lower oxygen affinity. But in sepsis too, you might see a suspiciously high saturation. And the reason for this is because in sepsis, the infectious organisms can actually interfere with the ability of oxygen to detach from the hemoglobin, right? So they might have a normal oxygen saturation, but not a lot of oxygen is actually being detached and, sent to the tissue. So I hope with these situations you can kind of start to form your own thoughts about different conditions and what might cause them to have a high or low SpO2. Some things to think about are, hey, if we have a hyperventilation patient and their saturation is really high, what does that change? What does that change about what we think about our patient? How does that change, what we think is going on inside the patient? And hey, what if the sat was low, right? What is that going to change about our patient? What is that going to change in our treatment, right? Because if there's anything to learn is that maybe providing just a direct flow of oxygen is not going to help some of these patients, right? You need to address the root cause that's causing the curve to shift and for the hemoglobin to not either properly absorb and hold on to the oxygen or to release the oxygen. So what is our major takeaway from this lesson? Well, the main thing is that SpO2 is a tool. It's often unreliable, but it can be very useful in the right context. What's most important, though, is talking to your patient, assessing your patient, putting your hands on your patient, listening to your patient, listening to their lung sounds, taking in the context in which you are seeing your patient, right? But when properly utilized, you can learn a lot from SpO2. So right here, you've got your normal body pH. I mean, it's a range, but this is the average. And what we've learned from this lesson when we are using SpO2 properly is that as you have a higher pH, you become more alkalotic. You're going to have a higher affinity, right? Your hemoglobin is going to have a higher affinity for oxygen. It's going to want to hold on to that oxygen more, right? And this is going to be, this higher pH situation is going to be something like hypokalemia, right? And then on the other end, lower pH, you're going to have a lower affinity for oxygen. This is your acidic states, right? So this is going to be something like sepsis, septic shock, right?